Next, I invite Dr. Lalit Verma, and sir will be speaking on 1, 2, 3 of anti-VEGF agents.
Thank you, Srini, and thank you, Namrata Santosh, Namrata Sharma for designing this session. You see, once she became chairman of the scientific committee, she said that she will do an AIOS session in all the state annual conferences, which is a welcome step. But I don't know, because of multi-specialty session like this, how much impact will it have that I speak on retina, cornea, because we will have a mixed kind of bag here. But nevertheless, it has its plus points that different specialties tend to put forward what's happening in the today's world. So I'll be talking of one of the most hot topic in retina, that is the anti-VEGF injections, which is today the bread and butter of all retina surgeons. How? Next, it's not. Okay. And I'll be talking this. This is not a research paper. This is just an overview of anti-VEGF agents. And on one fine evening, I thought I'll speak on 1, 2, 3, 4 of anti-VEGF. You see, anti-VEGFs have revolutionized the management of all these retinal vascular disorders, including DME, in fact, diabetic retinopathy also, NAMD, RVOs, ROP, myopic CNVM, so many. The first anti-VEGF which came with a big bang and went out with a very big bang also was Macugen. No longer Macugen is being used anywhere across the globe. Macugen, I once in one of the conferences labeled as a pure water only, hardly any chemical, this thing. So in today's world, I divide anti-VEGF into two parts. First generation anti-VEGFs, which are off-label bevacizumab, then we have ranibizumab, and then we have aflibercept. And so many biosimilars have also entered into the market of ranibizumab also. Aflibercept biosimilars are in the pipeline, and hopefully next year we will have so many of aflibercept biosimilars. Second generation newer anti-VEGFs have come up now, and these are very promising. These are led by brolucimab. These are all monoclonal antibodies, then faricimab, and then high dose of aflibercept, that is 8 milligram aflibercept. So this is the way I now classify anti-VEGF agents. The pharmaceutical markets are today flooded, and every company will come at your door and say, prescribe this one, this one, this one. And there's a tug of war going on between all these companies. Everybody is going to price it little lower, 100,000 rupees here and there. Anti-VEGF innovator molecules are also there, and biosimilars also there. Believe me, all of them work. All of them are reasonably good with some percentage here and there. And the current issue, believe me, as I see it, in anti-VEGF market is only one, and that's durability of the injection. Because patients are fed up today of going every month to the doctor, every month OCT, every month consultation, every month travel. Believe me, this adds to the cost of the injection. And newer anti-VEGF molecules are being developed primarily with single aim, that is to increase the duration of injections. So you see, there's a distinction between RCTs and real-world scenarios. RCTs may show excellent results, because RCT I label as a red carpet treatment, because here the injections are given to the patient as free of cost. But in real-world scenario, where patient has to pay from his own pocket, he realizes the pinch of that payment, and therefore compliance issue comes in. So as I said, there is a tug of war between all these biosimilars, and they are not only efficacious. All these biosimilars which are in the market, they are efficacious, but they are also cost-effective to the innovator molecule. So this is one example of one of my patient who did respond. You can see this edema coming down here, but again. And one day this gentleman brought a chart. Doctor Saab, how many injections will you keep giving? And believe me, sometimes this may create an element of distrust also. So injection. Not only they are physically problematic for the patient, but also mentally also patient has a setback in this. And I remember one of the bank managers asking me, doctor, is there any permanent solution for this? Can I come less frequently? So at that time I said no. But today I can say yes. So I tabulated all the anti-VEGF which are available, bevacizumab, ranibizumab, and the lower line, which is red box. So this shows the approximate duration of action. So aflibercept is proposed 6 to 8 weeks of duration. Brodusumab is piped as, as 12 weeks. And the newest anti-VEGF, which is in the market maybe in a month or so, 15 December is the deadline, this will enter India's market, Faricimab. Although it's got approved in 2022 in US, but I labeled one month, 1, 2, 3, 4 means 1 month, 2 month, 3 month and 4 month. This is the durability of the injection. And the last is the cost of the injection. So if you see the last two molecules, less the interval or more the duration of injection, the cost tends to come down because patient tends to spend less. So these are the various studies, based on which a lot of these molecules got approval in NAMD, Anchor, Marina, View 1, View 2, Hawk and Harrier, Tenaya and Lucerne. And on the right side, I have listed 1, 2, 3, 4 of all these anti-VEGF injections. So I'll not go through this Marina Anchor. This was the first pioneering study of ranibizumab. For the first time, they showed that graph can go up. Up means patient can gain vision now. Not only maintenance of vision, but gain of vision. And this is the View study of aflibercept, View 1 and View 2. Then Hawk and Harrier for brodusumab came up. Then Tenaya and Lucerne for faricimab. Similarly, for diabetic macular edema, remember always two parallel studies have to go on for FDA approval. We had RISE and RIDE for ranibizumab, then Vivid Vista, Kite and Crestel, then Yosemite and Rhine. Again, 1, 2, 3, 4 of all these anti-VEGF injections. So I'll again skip this RISE, RIDE study, Vista and Vivid, and Crestel for brodusumab and Kite. These are the latest talk of the town, Yosemite and Rhine study for faricimab, where they claim that Q16 can be obtained in at least 70-80% of patients. So thus to conclude that, we have gone far from 1 month to now 4 months of injection, and this is a good step, a welcome step and a positive step. So world is, believe me, moving very fast, and every day so many studies are going on. So 1, 2, 3 months is primarily duration of action. We have moved from 1 month from bevacizumab to ranibizumab to 2 months of aflibercept, 3 months of brodusumab, and now 4 months of faricimab. The ultimate barrier, believe me, is the cost and the durability. And COVID era told us that we used to inject, at lesser frequency, but it did help. So molecules which have longer duration of action, the compliance improves, and hence the cost comes down, and treatment effect also is better. So thank you very much for listening to this 1, 2, 3, 4.
Thank you, sir. Thank you for the wonderful